Hi, I'm Terry Kuti. I'd like to welcome you to Deep Sea Foundation educational channel, where we talk about all options for breast reconstruction and topics related to breast reconstruction for those affected by breast cancer. I have a great guest today. His name is Dr. David Light, and he practices in Great Neck, New York at NYBRA, which stands for New York Breast Reconstruction and Aesthetic Plastic Surgery. He's a fellowship trained, board certified plastic surgeon with a dual practice focused on breast reconstruction and aesthetic surgery. Today, we're going to chat with him about delayed and revision reconstruction for those affected by breast cancer. We're filming during the pandemic, and I want to roll in the topic of telemedicine today, Dr. Light. You and I have spoken about this, and so we'll roll that into the conversation, what changes you have seen in 2020 and 2021. But honestly, here's the thing. Many of the leading microsurgery centers across the US, you guys have already been doing telemedicine far before the pandemic. So let's chat about it today. I'd like, first of all, welcome to the Deep Sea Foundation channel. It's great to have you.
Thank you. Thank you for having me. Appreciate it.
Yeah, absolutely. Let's talk about, we have spoken that during the pandemic, you've seen an increase in consults for delayed reconstruction and revision reconstructions. Give the viewers a definition between the two, if you could.
Sure. Usually when we use the term delayed reconstruction, it's referring to a reconstruction that is not happening at the time of the mastectomy. And so a woman has the mastectomy, and then at some later date, the reconstruction is performed. And that can be based on her choice not to have a mastectomy have a reconstruction at the time of the mastectomy, or she may have had a complication or an issue with her original reconstruction. A revision reconstruction is sort of what you would guess based on the term. It's revising or altering the patient's original reconstruction. And that can be for a variety of reasons, and issues that the patient may be having.
Yeah, that makes complete sense. Makes complete sense to me. So I know that there are specific reasons for women to have revision surgery, both implant-based and even autologous tissue. And I did have a delayed DIEP flap. I had the delayed procedure that you spoke of so eloquently at the beginning. Tell us why women would come back in for revision surgery for both instances.
Sure. So we get a lot of calls for women that are having issues with their implant reconstructions. The most common complaints are implant animation, and that's for subpectoral or implant reconstructions where the implant was placed under the chest muscle or pectoralis muscle. There's complaints of capsular contracture where the breast gets very firm because the capsule, essentially scar tissue around the implant, has thickened, and that can get to the point where it's actually uncomfortable, as well as altering the shape and deforming the breast shape. And then implant malposition is probably the rounds off the top three, meaning that the implant has moved with time, and classically they displace what's called inferior laterally, so down and out. And that can certainly be corrected with a revision to the implant reconstruction, something called a capsulorrhaphy, and oftentimes we'll use the biologic mesh or acellular dermal matrices like alloderm to reinforce the implant position. So elevating the implant, pushing the implant in. So that's how implant malposition is corrected. For implant animation, the best correction is actually transferring it from a prepectoral position from a subpectoral position to a prepectoral position.
Right.
So in other words, going back in, taking the implant out, putting the pectoralis muscle back down on the chest wall in its natural position, and then putting the implant in on top of the muscle. And that often will include some additional biologic mesh to support the implant and help to hold the position.
Mm-hmm.
The third option that we always discuss for anyone having problems with their implant reconstruction is removal of the implant and switching to an autologous or a natural tissue reconstruction, like a delayed DIEP flap, a delayed PAP flap, and there's obviously a number of other options that can be used. It's all the same concept, taking excess skin and fat from one area of the body and using it for the reconstruction to give them a nice natural reconstruction.
Right.
Once you do that, that immediately takes the capsular contraction problem off the table, and it takes implant animation problems off the table. So it's a great solution.
Yeah, and I know in the plastic surgery community, in the discussions and the webinars that I've been to over the past couple of years, or even at conferences, I've seen a trend in prepectoral. But I think a lot of it is due to the fact that, folks like you up at NYBRA, you have really, I know there's a lot of patient selection that goes into it, but I also know that it is perfecting the technique. Can you speak to us a little bit about that?
Sure. Yeah, I think it's a little bit of both.
Yes.
Prepectoral position became very popular. I would say that the majority of my practice is prepectoral reconstructions and conversion to prepectoral, but I occasionally still select a patient for a subpectoral reconstruction, and the patient is definitely involved in that decision making. We review the advantages and the disadvantages of each. When you put an implant underneath the muscle, subpectoral, it's actually hiding the implant. The more soft tissue you have covering that implant, the more natural it's going to look. And so there is that advantage. A prepectoral reconstruction, the reason why it's so popular, it's really a great option. You don't have to worry about implant animation. There's less immediate postoperative pain. You don't have that sensation of tightness from having an implant under a muscle. And so it's really a great option. However, in very thin patients, especially after a mastectomy where there's really not much soft tissue left, fat left under the breast skin, the implant can become more visible. So rippling, seeing the edge of the implant, and all of that needs to be part of the preoperative discussion so that the patient's truly making an informed decision.
Yes. And you see me smiling when you use the word decision, because one of my favorite topics, of course, is shared decision making. And I know that you engage patients in that at your practice daily, because it just improves patient outcome all the 100%. Way around.
Yeah. If the patient truly understands the advantages and the disadvantages, and not only for this surgery, but possible future surgeries, because breast reconstruction is often staged, that there won't be any surprises. Everything is laid out. And like you said, it's truly a shared decision. We're making it together, and they're comfortable with that decision. And it just makes the process so much smoother. And it's definitely, key to having happy patients.
Yeah, and risk versus benefits. But in that shared decision-making model also comes lifestyle, which you talked about, because activity, everything you talked about with the subpectoral, the animation deformity, that rolls into lifestyle.
Sure, absolutely. I mean, it's very classic for a woman that has a subpectoral reconstruction that has an animation deformity, that it is affecting their lifestyle. They'll say that, I go to the gym, when I'm working out, I'm wearing a tank top, or I'm wearing a tight bikini top. And every time I go to do a certain yoga pose or work out on weights or curls or whatever it is, anything that fires the pectoralis muscle, in a severe animation deformity, it's very, very visible. And it may be only visible during the contraction of the muscle, but it's a few seconds. And, they'll say, people asked me about it. Is there something wrong with my chest? And so it can be upsetting. And I can easily understand why. You also hear it in, in bathing suits and evening dresses, anything that's going to kind of show, the cleavage a little bit more and make the deformity more obvious.
Yeah, really great discussion today, Dr. Light. I really appreciate your time and clarity in discussing this topic with us today. Stay safe. Thanks for being on the channel and giving us great education. Really appreciate it.
My pleasure. Thank you for having me, Terry.
Absolutely. Take care.
Bye-bye.